I think you guys are going to walk through the opening slides.
Correct. So welcome. Good afternoon, everyone. My name is Dr. Inez Cruz, and welcome to Family Medicine Grand Rounds. Today is September 9th, 2020. Our event ID for the day is 253047. You can, of course, connect via cell phone, smartphone, computer, audio, whatever is most convenient for you. Next slide. We want to, of course, thank everyone in advance for muting your microphone once the presentation begins, and of course, attending to the presenters. Both Dr. Morrow and Jeannie have asked that if you have questions, please place them in the chat box. And then, of course, we will help moderate those for both Dr. Morrow and Jeannie. If there are any questions, of course, that don't get answered at the end, we will go ahead and make sure that those get addressed. Of course, that's part of being engaged in the session. And at the end, please complete and submit an evaluation form. Evaluations are, of course, important not only for grand rounds, but especially for the presenters and the feedback they provide. Next slide. So this is South Texas Regional Family Medicine Grand Rounds, which is offered in conjunction with South Central AHEC. So thank you to our educational partner. Next. CME transcripts can, of course, be obtained through our UTSCA CME, as well as, next slide, the AAFP website. Both of them are very responsive, so if you have any questions or have any needs that surround that, please, you can either get in contact with Nicole and I, or we can go directly to the vendors themselves. Next slide. And conflict interest, Dr. Morrow and Ms. Sauerland have no relevant financial interest or commercial interest to disclose. And I apologize, Jeannie, I think I just completely destroyed your last name. Next slide. She's like, no. So we would like to thank Dr. Morrow and Jeannie for presenting with us here today. We fight for each other, responding to the ethical challenges of COVID-19. And having said that, I will go ahead and pass that over to Dr. Morrow and Jeannie. Thank you so much for being here today.
Thank you, Dr. Cruz, and thank you everybody for being here. I see Dr. Nadeau, Dr. Hyen, I see Hannah, Jordan, a few other familiar faces. I didn't get to scroll through everybody, but we're really grateful for your attention today. It's going to be a little bit of a whirlwind, and we hope we get you thinking, and we hope you had a chance to look at the survey. I was able to take 23 respondents and analyze their data for today. So if you submitted late, I'm sorry that you weren't included, but you can still take the survey if you want. So our learning objectives are to identify and analyze key ethical principles and professional duties involved in clinical decision-making during a crisis, and to compare the actions that health systems should take during a pandemic to protect clinicians, patients, and the community. So Jeannie and I are gonna give you some high-yield strategies for helping health systems prepare and talk about what we're doing over at university. Around the country, hospitals are either feeling the opening barrage of a horrifying pandemic or rapidly scrambling to prepare for an onslaught in their own backyard. Every possible niche of healthcare is bracing for the likelihood of a deluge to come. I want you all to think back a little bit as the pandemic really set in and we watched it from afar. To me, in my metaphor, it was like there was this tsunami that hit our eastern and western shores, and it was just a matter of waiting for the wave to hit us. So we braced, we prepared, and we saw the suffering. We saw the stories of suffering from around the country, from families to providers. This series of graphic prints are from Dr. Nathan Gray, a palliative care clinician over at Duke University. If you want to find him online. In New York, nurses and doctors were overwhelmed, absolutely overwhelmed. Patients dying in the hallways, patients dying in the parking lots. In an interview with a nurse who represented a group of nurses that were not only leaving nursing, but suing their health systems, one said, "We didn't sign up to be sacrificial lambs. We didn't sign up to fight a deadly disease without adequate resources. We're told we're soldiers. Well, you don't send soldiers to war without a gun and expect them to do their job, but you're doing that to us." Among nurses who faced COVID-19 surges, there were higher death rates, multiple losses, high rates of burnout, nurses leaving the field. Was this a preventable adverse error in our system? And it begs the serious questions that the nurses asked. What does it mean to be a hero after the system fails to protect you? And is there an edge of insult to injury when you're called a hero, when you're making a sacrifice that maybe could have been prevented?
Jason, can I just add something to that?
Please.
As far as amongst the nurses and things like that. Ironically, 2020 is considered the International Year of the Nurse, and it's also the anniversary of Florence Nightingale's birthday. Originally, it was meant as a time to recognize and celebrate their contributions. More than 50% of all healthcare workers are nurses, and the situation, on the one hand, you've seen almost the hero worship of people that work in healthcare, the doctors, the nurses, the RTs. Oh, you're so wonderful. But on the other hand, a family member of mine who's also a nurse, after work ran into like Circle K to get a soda or something, and people were looking at her like a piranha, like, why are you here? You shouldn't be here. You're in scrubs. You're dangerous. Get away from me. So it's been a very interesting dynamic that illustrates how complicated this world of COVID has been on so many fronts. So just something to recognize.
You're right, Jeannie. And I recall in the early days here at university, not only was the hospital having to deal with allocating scarce PPE, worried that they might run out, but they made choices in messaging. And some of those choices, I remember being told to take off my mask because it'll give the implication to other people around the hospital that they should be wearing masks. I said, I brought this from home. They said, take off your mask. We're a system in crisis. In the midst of an outbreak, there are people who will die in relative isolation from their family and friends. For those of us who have built our careers around the idea that people should be able to find peace, meaning, and connection in their last days, that prospect is gut-wrenching. And if any of you have seen these hallways and wards where families are separated from their loved ones, and doctors and nurses and therapists and techs and our environmental service providers are providing care to people who are alone from the world they usually know. In a crisis, we as providers must balance our obligations. We have a fiduciary duty to care for and respect our patients. We have a stewardship duty to promote public safety and equity. We have a personal duty to care for ourselves and our families, and a professional duty to advocate for our colleagues. And in my mind, when you have competing ethical principles, the goal is to find a way to balance and reconcile them. There are times when one principle must give way for another, while still both are important. From our professional standards, the Hippocratic Oath of yore states, whatever house I may visit, I will come for the benefit of the sick. This speaks to the altruistic nature and calling of our profession. The AMA endorsed a similar mentality specifically in 1847. When pestilence prevails, it is the duty of physicians to face the danger and continue their labors for the alleviation of suffering, even at the jeopardy of their own lives. In 2017, updated ethics opinion, because of their commitment to care for the sick and injured, individual physicians have an obligation to provide urgent medical care during disasters. This obligation holds even in the face of greater than usual risks to physicians' own safety, health, or life. Nurses, too, from their code of ethics published in 2015, the nurse's primary commitment is to the patient. The nurse owes the same duty to self as to others. The equal obligations can conflict during pandemics when nurses must continually care for critically ill infectious patients. This is prescient, right? Often under extreme circumstances, including insufficient or inadequate resources and uncontained contagion. During pandemics, nurses and their colleagues must decide how much care they can provide to others while also taking care of themselves. They must be supported in these heart-wrenching decisions by their systems in which they provide care and by society. So clearly, this is an almost irreconcilable dilemma, the care of the self and other. And it's something to do with the calling as professionals that we have to be on the front lines and to situate ourselves at the heart of a crisis. When trying to figure out how to discharge your professional duty as an individual clinician, you also have to be mindful that you're the face of an institution, of an establishment that reflects a set of policies and priorities that are meant to serve the public at large. So clinicians as physicians and nurses are trained to care for individuals, while public health emergency requires us to change our practice to respond to the care of populations. And in an emergency, we are faced to consider the fair allocation of scarce resources. And in that regard, the Hastings Center, providing an ethical framework, argues that we are to prioritize the community. The shift from patient-centered practice to patient care guided by public health duties creates a tension within us, within the clinician, and that includes our ethics consultation partners. I was lucky to be part of the mayor's and judges' health transition team that issued a report in April for recommendations on how to help open up the economy while protecting the health of the community as stewards of the community. We endorsed beneficence, evidence-based decision-making and responsiveness to new information, respect for individual freedom and privacy. We do live in Texas. Trustworthiness, teamwork, transparency, accountability, and equity. It's hard to do all of this at once, but the idea is to find a way to maximize all of these. I was also fortunate, this is in April as well, to be part of a volunteer posse to go to our local nursing homes that were under-resourced, understaffed, and absolutely frightened about COVID positivity within their walls. Hospitals and the nursing facilities were jockeying for locations and positions and staff to provide care for at-risk patients. And I went door to door as part of a team with Metro Health, partnering with the Center for Medical Humanities and Ethics, door to door, talking to nursing homes about PPE, and they were scared. I think they still are. One of the lessons I learned occurred at one particular facility where they didn't have any N95s. And at that time, for aerosolizing procedures, the CDC was recommending having N95s. And really, as a facility, you need to think about your burn rate. You need to think about having 1 week worth of supplies so that every employee for every shift can have adequate PPE. So we're talking for these facilities, many of them hundreds to thousands of PPE per week available. And this facility had surgical masks, but not enough for a burn rate of a week. And they had 0 N95s and they didn't know when the next one was coming. So that was part of what we were doing, was trying to connect them with the Operations Center, the South Texas Regional Advisory Council, the STRAC, and the Metro Health to help resource these facilities. They were also nervous. Why are you here? Why are you knocking on our door? You know, they're so worried about being judged by Medicare and Medicaid. So one of the lessons from that came in talking to one of the staff leaders at a nursing facility. I said, well, what if you have somebody who codes? That's an aerosolizing procedure to perform CPR on somebody who's passed out. I said, you're going to force potentially a career nurse to make a decision between trying to save a patient or protect themselves. And that was the genesis of this survey that you guys so graciously answered. Question 1 was, Robert has worked as a registered nurse at the Sunny Days nursing facility for years. He's caring for Ms. Garza, a 70-year-old woman with poorly controlled diabetes who's had an escalating dry cough lately and new onset fever. Another recent resident was recently hospitalized with COVID-19, and Ms. Garza's swab is still pending. Robert is aware, current at the time, recommendations from the CDC to wear surgical masks for routine care and N95 respirators for aerosolizing procedures. He's wearing a surgical mask, and he knows that Sunny Days still awaits its next shipment of N95. Suddenly, Ms. Garza grasps her chest and passes out. She's not breathing. She has a thready pulse. Her full code status was recently confirmed. After assessing Ms. Garza and calling for help, what should Robert do? Select one answer. So the two choices were to perform CPR with a surgical mask in order to help Ms. Garza recover from her cardiac arrest. 70% of you recommended that Robert should jump in with that surgical mask and do what's best for the patient. 30% of you said withhold CPR to protect himself because he's at high risk for getting the disease if she is contagious. Some of your comments. I would do chest compressions, but I would not do mouth-to-mouth resuscitation due to the pandemic. Robert is in a difficult position. The planning on this was not good. N95 should be available. Since he's an RN, I assume he will not be intubating. If the patient is to be intubated, then full PPE is needed. The facility should have considered what sort of airway support they intended to have available. Excellent point. She's full code. Is there really a choice?
Here, I wanted to bring I wanted to bring up something too, as far as the full code and all those things. The American Heart Association at the beginning of COVID issued guidance, and one of those was that you should not code a patient unless you had full PPE on. Now, they were referring to COVID positive patients, but I was thinking back to when HIV and AIDS first appeared on the scene. We didn't know, you didn't know, and we were taught universal precautions. You must take care of yourself, because even though you may at least potentially save this person, you may turn around and give it to other residents, you may give it to your family. So, and it sounds perhaps a little cruel, but in the equation, possibly saving one life, but also risking many others. It can't be thought of in isolation. And so it's a very, very difficult situation. And I think our instinct is to just move forward. But COVID has made people have to step back and go, wait a second, what are the consequences of me doing that? What is the potential harm?
Yeah, the
versus
potential
the
harm
benefit?
to yourself and to continuing to discharge your duty as a provider. Yeah. Let's imagine somehow Ms. Garza is intubated and transferred by EMS to elsewhere hospital where she's in the EC pending admission. Her test for the virus returns positive. She then suffers another cardiac arrest. Her telemetry monitor shows no electrical activity. Maria is the first provider to arrive at Ms. Garza's room. Surgical masks, gloves, and gowns are outside the room, but N95 respirators and face shields are being stored on the other side on the crash cart. It's the other side of the EC. So what should Maria do next? Select one answer. I know you all hate ethics questions. Make me choose a terrible choice. So either immediately don a surgical mask, gloves, and gowns and initiate CPR as quickly as possible. In this case, you all said 35% of you would do that. Whereas 65% said, wait, get the right PPE on, even if it means delaying the initiation of CPR. Now think, what about your relevant differences here? I think one of the relevant differences is we know she's got it, right? She's positive. Another difference is that there is PPE, it's just down the hall. With the case of Robert, the choice was much more stark. She's gonna die if he doesn't do everything he can. But it's compelling, right? To see the differences in what we would do, what we think the right thing to do in a situation is. In both cases, we really want to protect ourselves, but we also have this professional sense of duty to care for the person in front of us. It's a scary and fearful situation. I need to think about myself and my family's health. I hope this is not a UHS facility. I am distressed that the level of preparedness is so suboptimal. But isn't that the point? Are we always going to be perfectly prepared? We're going to face ethical dilemmas because we cannot anticipate every hypothetical. We can do our best. And to that extent, maybe that's where a lot of our moral energy should be focused, is in preparation. We at the same time have to anticipate the dilemmas people face on the front lines because you can't plan for everything. So imagine a moderate crisis and a severe crisis. A moderate crisis comes, a wave of patients arrive, elective surgeries are canceled, patients are being added to occupied hospital rooms and staff ratios have been altered to accommodate more patients. Beds and ventilators are approaching capacity, though there are still some available. Which of the following actions should elsewhere hospital take to respond to this crisis? Or consider a severe crisis, an even bigger wave of patients arrive. An internal disaster has been declared. A backup plan has provided additional nurses and doctors. All operating rooms have been converted to ICU rooms, and there are not enough rooms or ventilators for patients who need them. Then what action should elsewhere hospital take to respond to the crisis? So for the moderate crisis, the overwhelming majority of you agreed with implementing crisis guidelines and algorithms to help doctors triage and sort out patients likely to survive and benefit from ICU and hospital admission, and establishing triage review committees to help doctors by providing consultation for prioritizing patients. A few of you endorsed saying, well, let's exclude patients with metastatic cancer and let's exclude patients with baseline coma. But really, you weren't buying into the other measures, such as blanket DNR protocols, unilateral DNR protocols, or just removing life support from patients who you didn't think could benefit from it. And that's what it looks like. Most of you put in implement crisis standards and establish triage review committees. Now, with severe pandemic, you recommend you shifted far to the right. Most of you still agree with implementing crisis standards and having triage review committees. But look what kind of recruitment we got for excluding patients with cancer, excluding patients with metastatic cancer from the hospital. Now, I know this is just an ethics survey, it's online, you're not married to your vote, nobody holds it against you, and I'm not saying it's the way you were always thinking. But it is interesting to see the kind of recruitment we get to excluding patients that we think can't benefit, won't survive. Blanket DNR policies, which means everybody's DNR for now, right? Unilateral DNR, discontinue, pulling the plug on people who were already ventilated, but maybe their family was saying do everything. I said over the objections of the family. So this is the data on that severe pandemic. 34% exclude patients with metastatic cancer. 13% said discontinue life-sustaining patients. Now the N is small here, but I've conducted the same survey with internal medicine and emergency medicine, and y'all are on very similar pages. In the event of a severe crisis where there are not enough ICU rooms or ventilators, what principles or criteria should you use to determine who is going to benefit from higher level of care? So this is a busy slide, walk with me. On the left, prioritize patients who are likely to survive the hospitalization in at least 6 months afterwards. Many of you put that as your first choice, and then the rest of you put it as your second or third choice. So you clearly like that criterion. Prioritizing patients who are able-bodied and have a high functional status. Not, about a quarter of you put as your number one choice, and you still got a lot of votes for second, third, and fourth criterion for prioritizing scarce resources. Then prioritizing patients who are younger, who have a full life ahead of them. Nobody picked that as their first criteria, but a lot of you picked it as your second and third. Prioritizing healthcare workers and first responders. A few people put that as their top choice, but a lot of you put it up there. So 1 through 4, 5, 6, it's up there. First come, first serve, kind of evenly distributed throughout. Most of you put it as a low criteria, a low rank list criteria. Random lottery selection, also somewhat evenly distributed, low criteria. And really nobody wanted to prioritize patients who have no funding or insurance as lower for resource allocation. And this is a graphic of the same thing. So in the setting of a crisis, which of the following groups should be willing to accept a higher than usual risk of harm to their physical and emotional well-being? Most of you put nurses, respiratory therapists, and attendings. A slightly lower number for the resident physicians, and medical students got the lowest vote in terms of being obligated to have a higher than usual risk of harm. And I like some of your very astute observations. It's a hard choice, but that is the chosen profession and comes with risk taken. It kind of goes back to the AMA and ANA codes. I think you could argue that residents should be included. I'm interpreting this that a higher than normal risk is still low. My risk as a physician on an inpatient service is higher than the risk for my brother, an accountant. Truth. Unless the accountant's working in a closed space and nobody's providing PPE. No one should be willing. The expectation cannot be martyrdom. Well, right, being noble would lose its virtue if you were required to do it, right? So we can't expect martyrdom. It would dissolve the meaning of what it means to be altruistic. So the question is, what is a reasonable expectation of risk for a professional? And somebody plugged in John 15:13, which I confess I had to look up. Greater love has no one than this, to lay down one's life for one's friends. Yes, that's the spirit of altruism and nobility. And that's what it means to be a virtuous person, is to put what your ethical principles and values are as your highest order. What should the community and health system do to support our healthcare workers? You guys were terrific. Make sure all resources are available, first and foremost. Like 18 of you out of 18 put that, who left comments. Under those conditions, no bias to those who are with or without financial support, race, creed, color. Community health leaders should be prepared and think about worst case scenarios, wellness support, and time for basic needs, public announcements and regular updates, right? Preventative measures so that there's adequate protection for our healthcare workers. Listen to the frontline workers. Provide specific and concise guidelines. Provide real support like food, grocery delivery, childcare, insurance pay, hazard pay, laundry and hospital clothing so fomites do not come home. I love it. I love the granularity, and that speaks of somebody who's been through this. So I made a word cloud of all the different responses, and you can see the priority that PPE gets when caring and supporting our workers. And this is something that's a conversation around the country. Right now, we're in a better place. But think about the road that it took to get here, and think about what will happen if flu and another rise in COVID comes at the same time. Everybody's going to want masks, and everybody's going to need masks in the hospital. And I got to confess, I reuse my masks. I reuse my masks because I worry about running out. I've got my own little small stockpile. But when I'm working COVID in the ICU and I'm seeing a lot of patients, I wanted to be able to change that mask frequently, frankly. The nationwide rage spawned by our health system's failings on display by inadequate protective equipment and support is not ultimately about masks or gowns. It is inflamed by pre-existing suspicions that the profit-driven structure of American medical care actually holds little regard for the well-being of its workers or patients. Now, I know this has an edge to it, but I think it's worth thinking about the social structure in which we are situated and the choices that are made for allocation of resources. Those decisions are made in advance, and they reflect the values that exist within a system, whether they are spoken or unspoken. The equipment crisis has only given these suspicions a physical form.
One of the things,
please.
I was going to point out too, it gives also voice to the values that society has. We build hospitals, we build clinics, we really, we have this new toy, quote unquote, to play with to address things after the fact, but we really haven't put as much emphasis on preventative measures of getting ahead of the curve, which is really the most ethical thing we can do. And one of the things that's been painfully evident by COVID is the impact that the social determinants of health have had, and that we haven't paid enough attention to vulnerable populations and the different groups. And as a result, we're seeing the death rates unacceptably high among certain groups. And again, because as a society, there's no money in prevention, quote unquote, and actually it saves money, but you know, it's a sad system. It's something that I think, and I'm hopeful, I really am hopeful that the lessons from this can make it better. We can just learn what we need to from this and then make the world a better place.
Well, I think you're right, Jeannie. These are social values at work, and one lesson to learn: when vulnerable populations suffer, we all suffer. There's no immunity from this virus by virtue of money. It can give you access to resources, but that's exactly the question, right? Is that should there be such unequal access to resources, whether it's among the community or our nurses and providers in our health system? When looking about how to support our providers, we have to think about how to support them in decision making. So this comes from an article in the New England Journal of Medicine in March. It was also reflected in the New York Times op-ed starring Ezekiel Emanuel. And this is what he and his group argues are the possible ethical values and guiding principles. So first of all, the utilitarian sort of consequentialist approach where you maximize benefits, save the most lives or the most life years, right? Maximizing prognosis. And for the pandemic, they argue that this should be the chief principle and that guides decision-making, saving the most lives. Now, again, that's hard when you're a clinician and you have multiple people. How do you choose among them, right? Well, another principle would argue for treating people equally, first come, first serve, which speaks of some sort of fairness because, hey, you got here first, but at the same time, why should that matter so much? Why should that be so important? Shouldn't it be more about how you present or whether you can survive or even need a higher level of care? And isn't there some inequity in the community? Maybe people who are well-resourced can get to the hospital faster. Some can come in their Lamborghini, some have to wait for the bus, as it were. Random selection would treat people equally, or would it? Because I'm not sure how you do it, because people do arrive in different order and have different conditions. So does randomness really promote equality? You could reward instrumental value, and they endorse this. You could say, based on what you've done in your life, If you volunteered as a research participant, then maybe you could get higher priority for the vaccine or access to a ventilator. Or prospectively, if you're likely to make a contribution to society, then you can, or like a health worker, then you should get priority. But I challenge you, are healthcare workers who end up in the ICU for 3 weeks going to go right back to the front lines? And who are we as clinicians? How good are we at deciding who is going to be most useful, right? That's a pretty reductionistic view. I could think a terrible doctor is not somebody I want to get back to the front lines, and I could think of a philanthropist as somebody that I do want to get back to what they're doing. So who are we to judge the instrumental value of other individuals? I thought I was trained to practice medicine. Giving priority to the worst off. You could take the sickest first, who are greatest need, right? Or they're in the greatest need for these higher resources, or the youngest first, because then you get quality of life years. They're going to live a long life afterwards. So I found some of these problematic, and what it reminded me of was that classic trolley car problem, where we fantasize about, okay, on one side of the tracks you have 2 people, and one side of the tracks you have 1 person. This one's young, and these 2 are old, and you're driving the trolley, and you have to make a decision: go left or go right. Or somebody's on the trolley, on the train tracks, and you have the brakes, and or actually you have another person that you could push in front to stop to prevent killing that person. In every permutation of the trolley car problem, which I'm a philosopher, I love this stuff. The challenge with the trolley car problem and fantasizing about tiebreakers you would make amongst 2 different people who present in your emergency room is that it invites unconscious bias. It allows you to play with your biases freely. Wouldn't it be better to focus our strategy for hypothetical decision-making to focus immediately on the clinical picture? Isn't it the clinical picture that matters more? So shouldn't we draw on heuristics that draw the attention of decision makers to the clinical reality and not some other instrumental value? And to that end, it's important to have what are called crisis guidelines. They've been published around the country. They pre-exist COVID. The World Health Organization, CDC, and many states have guidelines from prior eras. And in Texas and South Texas, the South Texas Regional Advisory Council has formed a crisis committee that I got a chance to be on, and we developed our own crisis guidelines that endorse ethical principles and clinical strategies to guide clinicians in how to make these really tough decisions in the setting of a severe pandemic. So for example, the principles are outlined here. Resource allocation should only be considered when necessary, while all efforts are made to reduce scarcity. You should coordinate with your regional medical operations center and state operations center. Don't act alone. A lot of people freak out and think that they're in crisis level 3 when there may be a health system next door that can take some of your patients. So coordinate with the state and your region. Surgical care and medical care should be based on usual ethical duties to promote effective and compassionate care, respect autonomy, and avoid unnecessary harm. Stewardship, equity, accountability require that scarce resources aims to save as many lives as possible while prioritizing resources for those who are in greatest need and are likely to survive the acute illness. Fairness and respect entail avoiding discrimination based on race, ethnicity, religion, gender identity, sexual orientation, disability, age, weight, size, inability to pay, homelessness, or perceived quality of life or social value, as well as incarceration, veteran, insurance, or immigration status. Those are not clinically relevant features that doctors on the front line should be making life and death decisions about. And then reasonable accommodation should be made to people with disabilities, so they are not adversely and unfairly discriminated against in the healthcare setting. The fact that somebody can't move their legs chronically has nothing to do with their prognosis in this setting. Guidelines should be reviewed and applied with the help of triage review committees. University Health System created its own triage review committee. We call it the Compassionate Care Committee, and Jeannie's going to speak on that momentarily. And the purpose of those are to review guidelines and provide timely support and consultation with updated information. Again, you don't want to make decisions in the dark, assuming the worst, when in fact you might have tons of resources that are ready at hand with some creativity. Membership should be diverse, and people should be trained in disability-specific training. Guidelines should be updated with information, and we should also be providing supportive, administrative, and consultative services for clinicians, as well as peer support and wellness programs. So these are an overview of the crisis levels. Crisis level 1, 2, 3. What I described as moderate and severe before are crisis levels 2 and 3. 3 is where there's just not enough resources to go around, and you've already done all you can to adjust within the health system to expand capacity. You don't have to read all this. The STRAT guidelines are published online. You can access them. The administrative roles to consider before a crisis and during a crisis are outlined here. Again, it's not just the fantasy of what to do if I have 2 patients who seem equally sick. It's also all the things you can do to preserve and expand capacity. We provide an outline of an algorithm in the STRAT guidelines. An outline of an algorithm that allows clinicians to walk through what to do in a crisis when you have potentially scarce resources. So patient arrives. First of all, you clarify their survival score, which I'm going to describe in a second. You clarify their survival score. If their survival score is green, that is, they're going to survive regardless of the hospitalization, then they get low priority for hospitalization, which stands to reason. You also have to assess their goals. A patient's goal might be that they only want comfort. Maybe they came off a hospice and found themselves in the emergency room. Or maybe their survival score is blue, meaning they're not going to survive even with a higher level of care. Well, those patients should be lower priority for admission to the hospital. And as the algorithm continues down to talk about the same algorithm for ICU. So really the struggle is to compare and deal with patients who have an immediate or high priority based on their survival score. In a level 3 crisis, you're going to prioritize those who are in greatest need and have most urgent need for a higher level of care and are likely to survive with that. So before I go into survival score and how you characterize the survivability of an individual patient, I want to offer Jeannie a chance to describe the Compassionate Care Committee and what role they can play for you at University Health System.
Okay, thank you, Dr. Morrow. The very first thing is similar to what we probably should be doing anyway, and it's trying to understand what the patient's values are, what the family's values are. This is how you can respect autonomy, just right out of the gate. Again, there may be some people, and I've talked to some people that said, look, if I get COVID, I don't want to be on the ventilator. I don't want to be in the hospital. I want to be home with my family. And I will do whatever I need to preserve that. We need, if we know that information in advance, it's very helpful to keep us from inflicting something on someone that they don't want. And it actually helps with the resource allocation proactively, because up front what the person values. And as much as it's possible, we want to maintain standards of care moving forward. It's just when we get in these crisis situations that they will be implemented. The Compassionate Care Committee, as it's been structured here, it is essentially a pandemic triage committee, but Dr. Alsop here said, the end goal is always to move people in the most compassionate way toward whether it is end-of-life care or whether it's aggressive medical care, but to always do so compassionately. And so it is a good name. Like I said, we do start out with the goals of care. Then if the triage level's clear, you go to where you need to be on that. Guided by these nice guidelines. And I appreciate what Dr. Morrow said about having them as a consistent basis. So a patient's not sure, well, if I go to Dr. Morrow, I will get this type of care if I go to Dr. Smith or whatever. And I'm not referring to any Dr. Smith, just using that as a generic name. It does open up the door for bias. If there's a question about, I'm not sure, or I'm not sure if this is the right direction to go, or perhaps there's 2 patients that are essentially equal, that's where the Compassionate Care Committee would come into play. At University Health System, because we have a full-time ethics service department, we would be the primary point of contact to facilitate the discussion, to get the group going. We have someone who is a triage officer. That is someone that is a physician specifically trained in the guidelines, that is familiar with triage principles, who will try to intervene, talk to the physician calling for the assistance, and see if it can be resolved at the first level, which again, in most cases is preferable. If that can't be done, then it will go to the committee. I want everyone to know, it's really important to know the committee is not making the treatment decisions. That still is in the medical decision-making realm with the physician, but they can look at the situation, offer support, guidelines, and recommendations. One of the characteristics of the committee that's very important is it's a diverse group. It's not just physicians. We also have respiratory therapists, pharmacists, nursing, legal, community representatives, and was designed that way. One, to be transparent. Two, is that diversity allows for multiple viewpoints to be shared, because we all see things through a different lens, and it helps us get a bigger, more robust picture. And we did some training exercises when we were really, truly worried that we were going to be using this on a regular basis back a few months ago. And what was interesting to me is when everyone began talking, we found solutions that no one had really thought of on their own. But as a group, we came up with some alternatives. So how can we still provide care given the resource limitations that are facing us? So it was a very positive experience. In the committee itself, because the guidelines are living, the science is constantly evolving as we move through the pandemic. They're available to support physicians and revise as we need. So that's where we're at. And I think it's something that's very positive. If we get in a situation where we hit an impasse, then it could go to legal and the full bioethics committee. But this group is available 24/7 to respond to these situations. So that's just a real brief overview, and I'll turn it back to Dr. Morrow.
Thank you, Jeannie. That's wonderful. And I think people just should bear in mind, this is not a life and death committee. It's not that we choose, if we're on the committee, that we choose who lives and dies. We are providing support to clinicians who have tough questions. A lot of times with an ethics consultation, you say to somebody, well, tell me what you think you should do. And tell me your reasoning behind it. Well, have you thought about this? And then you support them in their decision. And that's the way that this Compassionate Care Committee works. It's a way to provide support and consultation. And there's nothing to appeal or override, although some places use triage review committees as the ones who make the decision. In the STRAT guidelines are some tools and tips for communication and self-care. If you remember, the front part of the algorithm says specifically that you have to address the patient's goals of care. So to do that, you must think of it as a process of informed consent, where you help to ensure that patients understand their condition, including the nature of the condition and the prognosis for recovery, the treatment options. You have to assess the patient's values and goals and document treatment decisions using advanced directives and entering code status orders. When exploring clinical milestones, and I've used this every single day, as a palliative care doctor and as a person conscripted to the provide COVID care in our ICUs, self-conscripted. I don't know if that's a thing. I think about empowering patients and families to think about clinical milestones that tell us whether they are on the road to recovery or they are not on the road to recovery. When you foretell, oh, your loved one's going to die, A, that's off-putting. B, that's polarizing, and it's C, unnecessary. We don't have to predict the future. We can help people understand what the signs are of which direction the future is going. And using that information and empowerment approach, then we can help people make decisions that are in line with their values. And frankly, will also help maximize the capacity in the health system. As an individual clinician, my goal is not to free up beds for other people. I'm here to advocate for that person. But as in a public health crisis, I have to be mindful of the whole system. So how do I do that? I give everybody the absolute same best care that I can give them by empowering them with information and an understanding of the clinical reality. To support our clinicians, we also want to make them mindful of some key syndromes they might experience when facing a crisis. And these are in the STRAT guidelines. I think it's one of the few guidelines in existence for a crisis that actually talks about moral uncertainty and distress. Uncertainty is when you actually don't know the right course of action or which principle or which value matters most. Moral distress is when you actually feel like you know the right thing to do, but you're unempowered to do it. Moral injury is emotional harm due to feeling compelled to witness or participate in actions that violate your conscience. And both moral uncertainty and distress can lead to injury. Compassion fatigue is where you witness trauma. It's secondary trauma, where you become numb, disconnected, or stressed. And burnout is when exhaustion, depersonalization, and a low sense of accomplishment burn in, and frankly, it leads to poor care and leaving the profession. We encourage people to anticipate and to respond to these syndromes, and here are some tips for that.
I wanted to point out that University Hospital, I'm sorry, is in the process of becoming a trauma-informed care center. That's an initiative that's starting. And on the info line, the little newsletter that goes out, there's also a resource, a free resource where people can call for psychological support. And I think this is very important because, again, this has been difficult. It's been difficult on the economic front. It's been difficult on the caregiving front. Just the human costs, not only to the families and the patients that have gone through COVID, but those that are at the bedside and those that have witnessed caring for them. So I think it's super important that we take care of each other and support each other, because this has been difficult, and to be willing to reach out for help, because there are resources. And I just would encourage everyone to do that.
Thank you, Jeannie. I think that's great to point out the new initiatives at university, including trauma-informed care. I also think GME and the chairs, the departmental chairs, deserve a shout out for helping resource the care needed to take care of our COVID patients. The truth is that one of the biggest causes of injury and burnout is just being ground down and feeling like you can't deliver the very best care possible. So by providing extra support, I think more people have been able to get through their day and get through this crisis season. For us, this pandemic means being ready to support our hardworking colleagues as they face risks to their own health, on top of the emotional toll that overstrained resources, death, and tough conversations can bring to us all. So what did we sign up for? Well, we signed up to care for our neighbors, our patients, and our communities, to lead fulfilling and balanced lives, to be inspired by and serve one another, our trainees and our colleagues, and to rise to our calling with a sense of humanity and justice. That's what we signed up for. And in COVID, we're trying to create a space where we can do the usual best care in a somewhat extreme time. And early on, I was jogging, discharging some of my emotional energy, and listened to this Rolling Stones song that came out as particularly salient. And I mean, it's from the early 70s, right? So who knew? Ain't nobody slowing down, no way. Everybody's stepping on the accelerator. This is when the governor was said, okay, everybody go about your business in June. And we knew what happened then. Don't matter where you are, everybody's gonna need a ventilator. What you gonna do about it? What you gonna do? What you gonna do about it? What you gonna do? Gonna fight it, gonna fight it, gonna fight it. So with that, we're gonna open up to questions and comments. There's probably been some chat. I'm grateful to all of you for everything you're doing to care for our patients in our community. And we're open for comments or questions.
Thank you, Dr. Morrow. Dr. Corman left a message in the chat that said, interestingly enough, there's a New York Times article out today discussing the the changes for COVID testing and failure to have those tests covered by insurance. Some patients were charged $2,000 for what was supposed to readily be available and free. So that's one comment. And then Dr. Hyan asked a second question, says, given that resources and health systems are often controlled by leaders that prioritize profit over all else, how do you engage and get their buy-in in effective ways?
So the question is how to engage leaders and get their buy-in to help take care of their staff. Okay. Somebody was going to say something?
Yeah, it was me. I just wanted to, hi. I just wanted to talk about that. So, cause like cut out on my end, but I thought what was such a salient point from the images, cartoons you showed us was talking about, like, we've had the suspicion that the medical system is run by greed, and the lack of PPE is just finally like evidence of that. And like, to me, that's what like hit the, like, that just like hits the nail on the head. And what I was referring to is actually, I was on the internet, and the New York Times is publishing now, people like, you know, we were told anyone who wants a test gets a test, your insurance will cover it, blah, 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 get a test, it's the safest thing you can do. But now there's people getting surprise billing, sometimes $2,000, you know, plus or minus, just for getting a COVID test or the care related to it. And so it's sort of like, it's just gutting, you know, like to have a health crisis where all of the burden is placed on individuals. Like, individual doctors must, nurses and healthcare workers must sacrifice themselves because that's the expectation, but the system, and all people must sacrifice, you know, going places and wearing masks and blah, blah, blah. But the infrastructure and the systems in place supporting that and the leadership doesn't like reflect that. Do as I say, not as I do, is almost how it feels. So I don't know. It brought up a lot of angst in my mind. So
I think tactically, the best way to get buy-in from leadership is to assume that you're on the same team. Sometimes those suspicions that we have about the intent of the system that has failed us or is failing us, those suspicions can become personal, and they can really undermine the ability to engage in meaningful dialogue. And that's the goal, because it's only through dialogue that you can work together and make progress. So I think you have to assume a posture of teamwork. I think you have to also speak the language of business and dollars and cents. Make a case, make an argument for why investing in PPE early, why giving time off, why having hazard pay, anything, why it would make financial sense. You can argue that if you have lower burnout of nurses and doctors, that you get better care, lower rates of medical error and adverse events, and lower turnover. And leaders care about the people that they've invested time in that have become leaders within their own system, clinical leaders. They want them to stay. That's a good investment, is keeping people around to do good things. So make a business case, show how it makes sense to invest in the support that people need, and also tell stories. Speak truth to power. Tell your own story. Bring the voices of vulnerable colleagues around you who have borne witness to really difficult things. Bring those stories to your leaders, because they didn't start as leaders. They got in those positions because they wanted to and because somebody else recruited them to it. They've got some sort of skill that you can tap into. So that's my advice on how do you recruit and hook the leadership. Dr. Cruz, what other questions or comments do we have?
Those are the two that were in the chat. Are there any other questions, Dr. Nadeau? I think is.
Jason, I had just a comment. So I think the tile that she's referring to was where it talked about, you know, people have some suspicion about the capitalistic system not having their best interests at heart. But I think in another universe, if we had a totally government-driven system, I mean, the suspicion would just be towards the other entity. I mean, I think people are going to be very concerned about their own personal well-being and always feel like, you know, they understand what their well-being does more than some third party that's trying to manage whatever these issues are. So I don't think that I mean, you can say what you want about capitalism. I don't think that particular issue is unique to a capitalist-run system.
This is Jeannie.
Go ahead, Jeannie.
I don't think so either, but I think I love your point. I think it's very important that those of us that work in healthcare be active, be the voices of what's actually going on. And I mean, regardless of your political beliefs, we do have an election coming up, and being politically engaged and involved and listening, hopefully to find a solution, because I think if we had a good one-size-fits-all solution, someone would have the Nobel Prize right now. I mean, you can look at different models and there's pros and cons to each. I don't think we found it, but I think what's happened is clearly illustrated that what we're doing now is insufficient for the needs.
Great point, Jeannie. And I think that there's also, of course, it's not unique to capitalism. The issue is the distrust that is inherent to power inequality. That is, you know, power inequality exists for the sake of efficiency. We can't, you know, we can't take care of our roads, defend our country, and provide a sort of social safety net like healthcare alone. And we can't leave it to private industry. So we have to create entities where power is concentrated. The way to bridge the gap is the principles that I described up front from the health transition team. We have to have a sense of transparency and accountability. We have to have the voices of diversity represented amongst those who are in power, so that there's a sense of understanding that our most marginalized communities have an advocate and have a voice, that the truth makes its way to those boardrooms where decisions are made. So that's a bit of a gloss, and I agree that it's not just capitalism, but we do have to, you know, if we do want to frankly expose and mitigate the risk that a profit motive could have that might threaten the integrity of professionals or vulnerable communities. But it's not just profit motive, it's inherent to power differentials. And our goal is not to break down those power differentials, but to bridge them, which is why I talk about using clinical milestones and informed consent to help my patients and their families make tough decisions. That doesn't undermine my own power as a clinician. I still get the white coat, I still get paid, I still get to go home after caring for the sick. But my goal when I see somebody who's vulnerable is to try to help them rise up as much as possible. And I think that metaphor, that model applies just as well to the establishment of healthcare, is that the goal is to take those vulnerable communities and marginalized communities, and honestly, including our nurses, and make sure that their voices are represented and that real resources are allocated.
And I think that goes to the point again, why the Compassionate Care Committee was designed to be interdisciplinary. I think on a community level, there's an expression, nothing about us without us. I think you need the voices from the different communities, from those that are disabled, from those that are a different ethnic group and whatnot, to see how they see things and what solutions we may come up with as a group, because it's really easy. We all have our biases, and to be aware of those. But I am very hopeful. I'm really a very optimistic person that now that we've seen the wound, that we can heal it, that we've got an issue, and this gives us an opportunity to move forward in the future and make things much, much better.
Hey, Jason, this is Byron, and Jeannie too, Byron Hepburn. I would welcome your comments to the group about the value at a systemic level of the RMOC and the STRAC in bringing for-profit and nonprofit health systems together to do this type of worthy work, like you've just articulated in the last hour. Standards of care, preparedness, resource allocation, and really developing a team ethos across historically competitive systems.
Excellent point, Dr. Hepburn. So the Regional Medical Operation Center, this and the South Texas Regional Advisory Council, these are extensions of the state, of the Department of Health and Human Services. They are not for profit. They are designed to represent the private hospitals, the community hospitals, the teaching hospitals, and the rural health setting as well. And the goal, now I'm not an expert in this, but I've had a chance to be on the crisis standards of care and the medical operations work group representing ethics and palliative care. What's beautiful is that the whole strategy is to prevent being in a crisis situation, is to create load balancing so that every patient, as many patients as possible, can get the care that they need. And this really requires responding to and anticipating crisis situations and watching them go to action. It's really incredible. And I see all the major health systems having dialogue in the meetings, and then they have offline meetings, and there's probably 20 different committees. It's really important, because we can't just fantasize about the tiebreaker situation, choosing between two different but equally sick individuals. We have to think about how do we keep ourselves from getting in a crisis in the first place, and that's where these regional and state operation centers and advisory councils do their best work.
And one of the things that's very exciting too is the Texas Medical Center in Houston, because of the things that they went through. I mean, very challenging. We now have a statewide Texas Ethics Consortium that meets on a regular basis to discuss not only what's gone on with COVID, but what's coming down the road, like how are we going to deal with vaccine allocation, to hopefully present viewpoints and perspectives to policymakers moving forward. So these items have been considered by a variety of people throughout the state. So the folks in the Rio Grande Valley and the Panhandle in the Bay Area and are talking to each other and sharing the best minds and the best ideas.
I like to, first of all, thank you both for a wonderful presentation and the whole structure of the way we're dealing with this crisis. But I think the elephant in the room from my perspective is that there is a crisis that was here before the crisis. And my concern is that we get so focused on COVID and we don't pay attention to the fact that there are millions of Texans that are uninsured, that they're dying early. They're dying from preventable conditions. And when we're post-COVID, are we going to go to the same process? Are we going to go back to the systems that were not responding to the crisis because it was a quiet crisis, a suffering crisis, but a real crisis? So I think it's good that we're paying attention to people who are marginalized. I think it's good that we're paying attention to everyone. And I think the principles you're articulating are right on point. But I think my concern is that, we're done. But the reality is, we still live in a state where the legislature has refused to expand Medicaid. So we have a huge number of people who are in the gap that make too much for Medicaid and too little for the federal insurance support. There is a big crisis under the crisis that is still bubbling. Our patients are not coming to us because they're afraid of COVID, but they're still dying from the consequences of hypertension and diabetes and other concerns. So I think it is important that we do this. And I think it's important for us to take credit for the fact that this is happening. And I'm very thankful for your leadership in this. But I think there is a larger picture that we need not to lose. And it's the fact that we have a huge crisis. We have a lot of a broken system. And I don't care if it's capitalist, socialist or not. The reality is that we are the only developed country that don't cover everyone in insurance, and we don't have a plan to make it work. And that needs to be something that needs to be highlighted very often. So thank you.
Yeah, Dr. Hyden, you make a great point. We don't want this bright, shiny object of COVID to be just seen as a one-off experience. The whole reason that we have higher numbers than we should is because preventative care and the research into caring for people in a way that prevents illness from getting worse is undervalued. And I wonder, I'll put the question back to you. The dialogue that you hear, the sort of polarized conversation about the use of masks and the worries, the distrust of the vaccines and some of the rhetoric, do you have hope that we can emerge from this with an improved dialogue about investing in preventative healthcare?
Well, I think my bias is towards primary care, because I think in primary care is where the rubber hits the road from that perspective. And the reality is that many people are not following, or we are promoting. We have effective ways to promote the spread. They're not being taken on, but then we are taking on the risk by caring for people in that case. So I am hopeful. I'm a hopeful person to begin with. I always see the glass half full, even if it's only a couple of drops. But I think it's important for us to talk about it and to at least address it in a proactive way, rather than to assume that it will solve itself, because it won't, because it hasn't for many decades now.
We are probably about 5 minutes over our limit, but I want to thank both the presenters and all of the different comments and questions that have been given. Thank you so much for your time, Dr. Morrow and Jeannie. We appreciate it. Any questions, we'll send them over to you. I did see one last question that popped into the chat, but we'll go ahead and email those to you with the person who sent it as well, so that way we can respect everybody's time.
And just let me offer, we are open to email. And also, if anybody wants to discuss further, particularly the nuances of the algorithm and the survival score and all that stuff, by all means, reach out to us. We're happy to do talks. I've done many talks for the neurology residents, medicine residents, the hospitalists. We're happy to talk to your groups about anything you like. So thank you all so much for your attention and for what you do. Take care.
Yeah, thank you again. I appreciate it.
Thank you so much. Have a good day.